everyone. Welcome to this webinar series organized by Saudi Society of Blood and Marrow Transplantation. We are going to have a series of webinars focusing on CAR-T treatment over the next few weeks. And we will have distinguished speakers during these webinars and highlight on important aspects of disease management using CAR-T therapy. I would like to thank the SSBMT for inviting us to moderate this session and webinar. And also, I would like to thank the sponsor of these activities, Gilead and Kite, for sponsoring this webinar and subsequent webinars related to CAR-T treatment. Today we have a distinguished speaker, Dr. Badr Al-Ahmari, who is a consultant of hematology and stem cell transplant cellular therapy at King Abdulaziz Medical City, Ministry of National Guard Health Affairs, Riyadh. He is also assistant professor at King Saud bin Abdulaziz University for Health Sciences. Dr. Badr has a special interest in management of acute myeloid leukemia and myeloid malignancy, focusing mainly on transplant aspects for these diseases. Also, at King Abdulaziz Medical City, he is the lead person for CAR-T program, and he wrote the guideline, and he's leading the CAR-T committee in our hospital, King Abdulaziz Medical City, Riyadh. So Dr. Badr is going to talk about a very important aspect of CAR-T treatment, which is early referral and CAR-T eligibility for relapsed refractory diffuse large B-cell lymphoma. Dr. Badr, you can start your presentation. You are muted, Dr. Badr.
Sorry for that. Right. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good evening, everyone. Thank you, Dr. Mohsen, for the kind introduction, and I would like to thank the SSBMT for the invitation to this important webinar series. It is my pleasure tonight to present the first episode, which is an early referral, importance of early referral, and CAR-T eligibility for DLBCL. So, trying to advance the slide. Okay, so as we know that T-cell immunity is very important pillar of management of oncological diseases in general. T-cell has a smart way to prevent disease, cancer progression and relapse, and has been proven in many aspects, and it's the cornerstone for management of many hematological and solid malignancies as well. Example for that, the use of a checkpoint inhibitor to enhance and augment the effective function of the T cell. One of the most important thing in how to help T cell recognize the tumor cells, and one of the ways is the use of chimeric antigen receptor modified T cells that has the ability to recognize directly the tumor cells and exert its effector function. So what is the chimeric antigen receptor? It's basically designed receptors in a modified T cells using two portions, using the external domain that has the antigen recognition site, and external domain that has the part of the TCR receptor, which is the important component for T cell activation. The antigen part usually consists of the most common antigen that can target a certain tumor without targeting the normal tissues. An example for that, the use of CD19 which is a band B cell antigen that is expressed radially in majority of the B cell malignancies. So T cells in general usually modified with the help of viral vector that introduce the construct into the T cells. Subsequently, the T cells will be expanded, and they will be able to express the CAR. And these T cells, when it's get infused, they recognize directly the tumor cells based on the target, which usually in the B cell malignancies is the CD19. And after the recognition and engagement, so expansion of this kind of CAR T cell led to the exerted its effector function that led to the killing of the tumor cells. However, this kind of therapy has a complex journey. So patient journey is kind of complex. It's not the same thing that we used to do with the conventional use of immunotherapy, other immunotherapeutics such as monoclonal antibodies and others. So it's engaged multi-party into the development of this product, and usually it takes weeks and weeks from the time of cell collection into infusion. So in general, it started by recognizing and identifying the correct patient and clear the patient before the apheresis. So the cells will be collected from the patient, mainly T cells, and then shipped to the manufacturing facility. And in the manufacturing facility, a long process of isolation of the T cells, expanding them, and then the process of vector transfection, and then expand the T cells after the vector transfection, and the quality control for these T cells, and then the release for these T cells. It takes a time, while in the same time the patient usually they get the care of disease control with the use of bridging chemotherapy and low toxic bridging therapy during the time of manufacturing. Cells will be shipped to the manufacturing facility after that, and then patient will receive lymphodepletion chemotherapy and then receive the CAR T cells. So it's quite complex journey. This is why optimum selection for the right recipient of such treatment is very important. Someone who can hold on and wait for the treatment while it's got delivered to him. In general, we have around 7 products that is already approved for different kind of hematological malignancies, using most of the product targeting CD19. However, 2 products for multiple myeloma targeting BCMA. There are large set of indication of different kind of malignancies, including large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, acute lymphoblastic lymphoma, recently CLL as well as multiple myeloma. But for the sake of this presentation, focusing the diffuse large B-cell lymphoma, we have 3 main products that treat diffuse large B-cell lymphoma. We have Axicel, mainly indicated in the second line setting for patient who relapse after first line of chemoimmunotherapy, who are refractory to that first line, or who relapse within 12 months of that line. And the second indication is after 2 lines of systemic therapy, kind of third line for DLBCL. Lysocell as well share the same, relatively the same indication at the second line and as first line as well. And Tacicel is only approved for third line for the diffuse large B-cell lymphoma. So as we know that once diffuse large B-cell lymphoma progress after the approved first line of chemoimmunotherapy, those who relapse, which is constituted around 30 to 40% of patient population, they do have a poor outcome. And this outcome is even got worse for those who are refractory to the second line therapy, I mean the salvage therapy with a median overall survival of only 6 months based on the pool analysis from different prospective and retrospective cohorts. So I will talk in brief about the three major products that we have before we jump into the field of eligibility and accessibility and early referral for CAR T cell. So in general, the three products, as I mentioned, they are approved for the third line treatment. Looking into the clinical trial in general, we will talk about the major differences. Axicil has the CD28 co-stimulatory molecular domain, while tacicin and lysocil, tacicil has only 41pp domain, while lysocil has both domains, CD28 and 41pp. And this might be the one that results in some differences in the outcome between different products. It is related to the issue of T cell persistence and others. In general, within the clinical trial, both the ZUMA-1 trial that led to the approval for Axicil in the third line and also for the Joliet trial for Tazocil in the third line did not enroll patients with active CNS disease. However, this was allowed in the Tazocil trial. Also did not allow for prior CD19 CAR T cell therapy. However, they allow in the lysocil they allow the exposure to the previous CAR T cell. Bridging chemotherapy was actually not allowed in the ZUMA-1 study, while it was permitted in the other trials. In general, patients who are enrolled in the three trials, majority of them they got infused. However, still fraction of patients they were not able to receive the infused collected cells for different reasons. Some of them were very few of them were manufacturing failure. However, majority of them are due to different factors, including disease progression, and we'll talk about that. In general, we can see that there is a little bit older population in the lysocil group compared with others. But it is very important here for our topic today that you can see that the highest, you can look into the range of the patient enrolled into the trial. You can see the highest around the age of 70, compare with the age of 80 in the lysocil group. However, and also patients who are above age of 65 years were around 20%, 25% in the ZUMA and Joliet trial. However, in the Transit trial were around 42%, indicating that generally an older population. You can see that universally ECOG performance status was 0 to 1. ECOG 2 were universally excluded. Moving into quickly into the efficacy data, in general, the overall response rates were in the range of around 70 to 80% across all trials, with a median overall survival was the 12-month overall survival was 59 in the ZUMA-1, 48 in the Joliet study, and 57 in the Transit study, which is indicating that there is a relatively similar overall survival. However, the BFS was around 12-month BFS was around 44% in the ZUMA-1 and 44% in the Transit trial, which is relatively equivalent. We do have longer follow-up data for ZUMA-1 and Joliet. In terms of toxicity, they were similar across the trial. However, you can notice that there are an increase in the neurological event noticed, especially the grade 3, noticed when the ZUMA-1 trial compared by others. The use of Axicil in the second line was tested in a randomized study, which I will not go into details, but which clearly showed that there is a superiority of the use of Axicil in the second line setting compared to standard of care, which is salvage therapy followed by autologous stem cell infusion. The study met its primary endpoint, where the progression-free survival was superior for the Axicil, with a median PFS of 8.3 versus only 2 months for the standard of care. Similar thing was also seen in the Lysocil in a phase 3 setting, where the median event-free survival was 10 months versus 2.3 months in the standard of care. So both products are approved for the second line setting. Applying this into real world and into the practice, multiple publication for Axicil and Diasocil as well were published, showing that there is an excellent reproducibility of the data that was seen in the clinical trial. I'm presenting here an update in the EHA 2025 for using the real world data from the CIBMTR data set, looking into the second Axicil as a second line, focusing in the subgroup analysis. However, I would like to highlight here that around 50% of patients enrolled into this data analysis were actually would not be eligible for the criteria in the ZUMA 7, mainly because majority of patients included here were actually not eligible to transplant to start with. Also things related to echo performance status as well as comorbidities. However, in general, overall response rate was actually very reproducible compared to the original study, the randomized study, and as well as the duration of responses. I would like to focus here into subgroup analysis, looking into using a multivariate analysis. When in this study, age was actually of significance, where patient above age of 65 and also patient above 75 as well, both of them were associated with a worse overall survival. So it's very important to account for age in this kind of setting, as well as patient with cardiac comorbidity were associated with worsening overall survival. Looking into safety analysis, again, older patients were highly associated with a higher grade of neurological toxicity, with a significant odd ratio of 2.25 for any grade ICANS, and as well as grade 3 and higher ICANS, and also patients with ongoing infectious comorbidity, they were associated with prolonged neutropenia. Other data also showed that one of the most important complication that we see post-CAR is the prolonged cytopenia. And there has been multiple publication looking into patient-related factor, treatment-related factor, and disease-related factor that really impact the development of such complication post-CAR T cell. So patients who are heavily pretreated are highly associated with the development of such complication. Pre-existed cytopenia prior to CAR T cell infusion were also associated with that. This kind of complication, the disease related, the type of disease that use CAR T cell, whether this is acute leukemia, myeloma, indolent lymphoma, it is also impactful, and it was associated with higher cytopenia when you treat, for example, acute lymphoblastic leukemia with CAR T cell. Other markers, including the disease status with the high LDH level and disease burden, was also associated with worsening outcome in terms of cytopenia post CAR T cell. In the real world data as well, the use of Axicil was in a real world data set they found that patient with equiperformance status of 2 or high LDH were actually associated with both worsening progression-free survival as well as overall survival and age, as I indicated previously. So moving into the patient journey, it's very important to understand the patient journey, as I explained earlier, for whenever the patient gets referred for the CAR T cell. In general, patients who are referred to CAR T cell center, they get discussed within a tumor board to make a decision about whether this patient is eligible for CAR T cell, as I mentioned, based on the multiple factors. The most important thing, indication, comorbidities, performance function, performance status, and other factors, including for example, social status, whether there is an available caregiver or not. And we'll talk about the importance of this factor and other factor that is important in identifying whether a patient is eligible for CAR T cell or not. There must be a multidisciplinary approach to identify patient eligibility, including involving the other services, including infectious disease referral, neurological evaluation, as well as the social worker, psychological assessment, and others. So it is very important to identify this factor, and also factor into this is the time when to collect and whether the patient is ready now to collect. Is disease status allow for waiting until we find a slot for cell collection, or do we have to do some kind of therapy? And if we do that, we should factor into this the importance of washout period. And I will not talk deeply into this, but this is very important because certain chemotherapeutics and immunotherapy will affect the quality of the product that will be selected. So the washout period is very important before the proceeding into or considering initiating this before the leukapheresis. So the best thing is to collect leukapheresis, to do the leukapheresis as early as possible, to clear the patient for leukapheresis as early as possible before any lymphoma-directed therapy. However, if not that possible, then selection of lymphoma-directed therapy is very crucial. In general, we're trying to avoid any, for example, bendamustine-based intervention, because bendamustine associated with very delayed T cell recovery post-infusion can reach up to many months before the full recovery of the lymphocytes. So it's very important to consider that, and having an active discussion between the cell therapy or transplant physician and referral physician to decide what kind of therapy can be initiated before the leukapheresis. So after the leukapheresis, bridging therapy after leukapheresis is also very important, because when you look into this specific aspect, you don't want a patient go into the time of the CAR T cell infusion, which is around between 3 to 4 weeks between the collection and infusion in general. Patient has to be in a good status, so you don't want to do intensive salvage chemotherapy that can affect the patient's status at the time of cell infusion. So selection of what kind of bridging chemotherapy is very important. An active discussion between the referring center and the transplant center is very important as well. Also, it's very important to, as I mentioned, involve multidisciplinary team into the process of evaluation, involve the clinical pharmacy as well into this, because many of those patients are elderly population with a multi pharmacy medication that has interaction with some kind of therapies that we use during the CAR T cell management. So it's very important to be evaluated by someone dedicated for this specific aspect. And then clearance before lymphodepletion. It's very important to make sure that patient does not have an active infectious process or cardiopulmonary toxicity from the bridging therapy and others before deciding for the initiation of the lymphodepletion and finally the CAR T-cell infusion. So the journey from the patient identification into the infusion is very important. And it's been estimated to be long in the past. Based on this data, it can reach up to 200 days between the time of the referral until the CAR T-cell infusion. However, over years, for example, in this specific one of the specific centers, they analyze their data and look into what are the referral time between the time between the referral into the infusion, and they showed that the time has been improved over years, but not perfect because still even for the recent years the time was actually can reach up to 3 to 4 months between the referral to consultation until the cell infusion. And what's important here as well, when they analyze their data, they look into those DLBCL patients who are primarily treated with Axicil. However, other CAR T-cell were used, but primarily predominantly was Axicil used in this setting. That around 40% of patients they were found not eligible for CAR T-cell infusion, and the major reason was actually the disease progression or poor performance status, comorbidities, followed by other indication, including availability of the caregiver, socioeconomic status, whether they have an adequate insurance or not to cover this kind of therapy. So it's very important to understand the barrier between that's divided in general between we call it physician-related barriers or patient-related barriers for the treatment of patient with diffuse large B-cell lymphoma. If we talk about the physician-related, there is sometimes a gap in knowledge and understanding whether what is the efficacy of the CAR T-cell across different line of therapy, because we know that we have more and more product for CAR T-cell. We have also from the same product, we have more and more indication moving between different lines, like moving from third line into second line and so on. So keep the update about the this kind of knowledge is very important to address this issue of efficacy as well as the safety of the CAR T-cell. Many of referral centers, they still think that this is too toxic for their patients. However, I mean, with the more and more updated data, we can see that the CAR T-cell is being used for more and more older population based on the real world data that I just discussed. There's also issue of lack of understanding of adverse event management for the referral physician, because sometimes those patients will go back to the referral physician and they think that long-term management of those patients is kind of complex, and it might be a burden for the institution to treat such long-term complication. Sometimes there are some late referrals from the referral centers. Other aspect related to the patient, we call it patient barriers, is patient themselves, they might be hesitant to consider this kind of what they think it is a complex treatment. As I mentioned, in this data set, you can see that there is like 6% of patients, they decline the CAR T-cell, not because of anything, except that patient were hesitant about whether this is a suitable option for them or not. Disease burden is very important as a factor that can be a barrier for CAR T-cell treatment. The issue of financial aspect and financial burden, lack of insurance, the travel. Most of the CAR T-cell are localized in the big cities, where many of the patients are they are spread across the smaller cities. So issue of consideration for travel and other issues, including housing and so on. So that's factor that usually to be considered when considering patient referral. And the most important thing is lack of caregiver. Caregiver support is very essential. I mean, many of those patients, they must have a caregiver. For example, in our institution, our guidelines is clear that patients should have a 24/7 caregiver available with the patient, at least for the initial 8 to 12 weeks post CAR T cell. If the patient cannot provide a caregiver, patient will be by default ineligible to receive this kind of therapy, because we know even after patient discharge, many of those patients, especially elderly population, they will struggle living alone with any specific caregiver with them. So talking about the patient eligibility, so there are many factors that I mentioned that we consider whenever we think about whether a patient is eligible or not. Age is considered a factor. As I mentioned, many of the clinical trial, they were not, the age issue that was not specified, whether what is the highest cutoff for age, and we can see that in real world data, the age has been getting older and older. Organ function is very important. Performance status as well is an important aspect, whether there is an underlying existed neurological disorders or, for example, epilepsy or uncontrolled epilepsy. This is very important because those patients at the highest risk of developing neurological event, as I mentioned, and according to the data that I showed you. Also, whether there is an active infection or not, because those patients, they will receive B-cell directed therapy, and we know that this is really a very immunosuppressive treatment, and has been associated with significant morbidities in terms of infection. In fact, infection, one of the leading cause of death after the disease progression for those patients. And whether the patient has primary CNS disease, like CNS involvement, or involvement by the lymphoma, is also very, very important. We can, as I show you, that within the clinical trial, majority of those patients were generally universally excluded. However, we are seeing in real world data that this can be considered, and some of those patients has been treated successfully with the use of CAR T cell. But it's still very important to consider, to put this into consideration, whether the patient is eligible for transplant, for CAR T cell infusion or not. So in general, echo performance status should be something between 0 to 1 in general. There should be a bone marrow, adequate bone marrow reserve with adequate neutrophil count, adequate lymphocyte count, because you want to collect healthy cells for manufacturing. Also, there must be adequate platelet number. Above 50 to 75 is acceptable, unless there is a heavy involvement of the lymphoma, of the bone marrow with the lymphoma. There must be adequate renal function, eGFR of 60 and above. However, there are some data that can challenge this and show that you can still infuse CAR T cell for patient with a lower GFR. There must be also adequate hepatic function and adequate cardiac function. In general, ejection fraction above 40 to 45 is very important, because as I mentioned, in the real world data, they show clearly that patients with cardiac morbidity were really associated with a worse overall survival for those patient population. It's very important, as I mentioned, that according to the data that we show in the real world data, we are really not relying on the chronological age. So we think about the biological age, the frailty assessment, the echo performance status assessment, rather than looking into specifically into age. However, careful assessment for the like I would say careful geriatric assessment for those patients, whether they are fit to receive such a therapy is very important, and it's individualized and evaluated case by case. Also for the organ function, we can see more, as I mentioned, more data about lower eGFR for those patients, and it's very important also to to consider adequate bridging therapy before before the cell infusion as a kind of disease debulking. And a patient with active CNS has been considered in the real world data. And in fact, there was an abstract presented recently related to use of Axicil in a phase 1 study for a patient with primary CNS lymphoma and secondary CNS lymphoma, showing that this intervention is relatively safe and there is no excess safety signal compared what's known about Axicil, with considerable efficacy, waiting to have larger data sets to show that this is really something we can consider right away for those patients. So looking into what is the best practice to enhance the T-cell referral and overcome this barrier that I just discussed, and ensuring that patient eligible to receive this treatment. Coordination is very important. It's very important to have a dedicated team of coordinator who are experienced in the evaluation and accepting early referrals and evaluation of patient eligibility for CAR T cell, as we usually do for cell therapy in general, the stem cell transplant and others. So it's very important to recognize this. As well as it's very important to provide support for the patient in terms of social evaluation and social services engagement with the patient to facilitate housing, financial support if needed, or any other things that can facilitate their journey through this complex process. And having an adequate communication between the CAR T cell and referral centers with a direct communication between the hematologist is very important, and as actually also having an active engagement with the manufacturer to ensure that everyone meets their timeline to ensure adequate infusion of the T cell on the CAR T cell on time. So I think with that I conclude, and happy to have any question, and thank you for your attention.
Thank you, Dr. Badr. Thank you for the excellent presentation and overview about this very important subject. We will open now the floor for questions. And please, if you have any question, you can post it in the Q&A box or in the chat, webinar chat box. So we have a few questions posted already. So first question, how to ensure patients are fit for CAR T treatment when you assess them in the referral, Dr. Badr?
Yeah, as I mentioned in the presentation, this process is quite complex, and this can be assured with a multidisciplinary approach, ensuring that patient, when they get referred, evaluated fully by expert people in the specific area. So the transplant physician has to make sure that patient fits the eligibility criteria in terms of indication to start with, and making sure that the use of CAR T cell will result in the best possible efficacy and safety in the same time. Having an adequate evaluation of the performance status, cognitive function, organ function as well. So patient will undergo like full evaluation for organ function to make sure that there are no significant comorbidity preventing application of such treatment. As I mentioned, engagement with a social worker to assure that the patient compliance and will be able to cope with the difficulty of administering this kind of complex treatment is very important, as well as the psychological assessment and others.
Thank you, Dr. Badr. You know, some patients they are sick because of the disease. So how you differentiate between they are not fit because in general they are elderly and have many comorbidities and unfit, or they are unfit because of the disease symptoms and complications?
Dr. Mohsen, this is really an important uh, question because I think this is also important for the referring physician because there are an assumption that patient with poor performance status they may not be eligible for CAR T cell. However, we need to understand why they have poor performance status. Is it due to disease? I mean, especially many of those patients, I mean, they were up and fit just before their relapse, right? So it's very important to differentiate whether this poor performance status is due to disease or not. And sometimes it's true they have poor performance status because of the high disease burden, and patient with the huge disease burden they might not be eligible for CAR T cell because this is really affecting their performance status and associated with a significant comorbidity and others. So it's very important to evaluate fully whether the CAR T cell infusion will result in improvement in their performance status that is primarily due to the disease. So it's as I said, it's a multidisciplinary approach and active communication between the referral center and the transplant center. It's very important to understand that CAR T cell is not as difficult as let's say autologous high dose chemotherapy and autologous stem cell transplant. And many of the patients who are not eligible for autologous stem cell transplant, they will be actually eligible for the CAR T cell. So active communication, engagement, understanding the cause for the poor performance status is very important.
Yes, thank you, Dr. Walid. Talking about performance status, there is a question about the performance status. How do you assess in practice the performance status of the patient when he is presented to you in the clinic or when you assess him in the inpatient service? And what level of performance status you say this patient is not fit for CAR-T?
So in general, patients who are taking care of themselves primarily does not need a lot of assistance to execute daily living activity. Those patients usually benefit from the from CAR T cell and will be able to withstand the toxicity that we see sometimes with the CAR T cell. So it's very important. Those with echo performance status 2 and above clearly was shown they were actually universally excluded from the from the clinical trials, and also in the real world data, two data sets of real world data, one for dedicated for axicil and one dedicated for lysocil. They both agree that echo performance status was a factor that can be considered when treating patient with CAR T cell and usually echo performance 2 and above was actually associated with worsening overall survival. So it's really important. It's difficult, yes, to understand whether this is bone first due to disease or not. But in general, if it is due to disease, it's highly likely that patient will be benefiting from the use of CAR T cell for this specific indication.
Thank you, Dr. Badr. We have a question from Dr. Mus'ab Damlaj. Nice to see him with us in this webinar. He was one of our staff in our hospital before. So Dr. Mus'ab is asking about for isolated CNS relapse after frontline diffuse large B-cell lymphoma treatment. Is Axicil a possible consolidation option after CNS-directed therapy?
يا أمسي على الدكتور مصعب دمج الحقيقة and it's good to have him tonight with us. Of course, as I mentioned, that use as a consolidation of patient achieve remission after CNS. I think this was his specific question. I'm not aware about any data that whether Axicil as a consolidation after CNS remission for isolated CNS disease is resulting in better outcome. However, as I mentioned, recent pilot study it was actually a phase one study that was presented at the last Lugano meeting, I believe, for the use of Axicil in the primary CNS lymphoma and secondary CNS lymphoma relapses. Usually, the university, it was actually primary CNS lymphoma relapse. The use of, and primarily was a parenchymal disease. The use of Axicil was safe. There was no an increase enhanced safety signal, and indicating that this is could be more toxic for those patients. And also, it was effective. There was, although the follow-up was short, but there was an excellent overall response rate exceeding 50%, and there was a durable remission despite we have only short follow-up. I hope that I was
But
able
uh,
to address
but in
that.
this setting, Dr. Badr, usually we go for autologous stem cell transplant after giving CNS-directed therapy. We don't have any studies comparing autologous versus CAR T.
No, we don't have. For CNS disease, we don't have. As I mentioned, uh, for this study that I mentioned, those majority of patients, they were actually relapsed after autologous transplant.
Okay, good. We have another question saying, I presume consent will be secured before and thorough explanation and assessment done, but in case the patient refused during the therapy, can it be preserved and will be given to other patients who need it, or it will be wasted after the preparation? So the patient collected, and before the infusion, the patient refused to receive the infusion. The question, can we give this treatment to other patients?
Yeah, unfortunately, I mean, this is unfortunate situation, and we see this often with the patient who have disease progression while waiting for their CAR T cell. However, in general, this is an autologous product, so this will be exclusively for the patient that we're collected for. So to answer it short, and we cannot give it to another patient, and it will be destructed as per guidelines.
Thank you. Dr. Ahmed Askar is asking a difficult question. Who would you consider for CAR T as next line, and who would you give bispecific antibody before CAR T?
I would assume the next line, that mean second line. Is that correct? So as you mentioned, Dr. Mohsen, it's a very hot area, and there are a lot of ongoing clinical development in terms of clinical trial trying to answering this question in terms whether to use CAR T cell or bispecifics. So not all patients fit for CAR T cell, fit for bispecific are fit for CAR T cell. So looking into evidence-based answer, we don't have an evidence-based answer whether to use CAR T cell for versus bispecific. But we know that for CAR T cell, we have a longer follow-up data, and with an excellent outcome, I would say. And also we have there are some plateauing in the survival care for some of these data sets, indicating potential cure associated with the use of CAR T cell. So CAR T cell still considered to be the standard of care in certain indication, including those who relapse after first line of therapy within 12 months, or they are refractory to the first line, whether to use Lysocell or Axicil. So that's based on the randomized study. There are some data showing that use of bispecific in combination with other chemotherapeutic agent can produce durable remissions. But until now, we have CAR T cell, the one associated with the longer follow-up. Bispecific is considered to be one of the important lines of therapy, and there are even data indicating that uses bispecific can salvage some of those patients who relapse after the CAR T cell. So it's a considered an excellent line of therapy.
Thank you, Dr. Badr. There's a question by Dr. Ahmed Shahid. I think he's talking about if the patient is having lymphopenia before collection. Should we wait until recovery of lymphocyte, or is it absolute contraindication, meaning that we will not collect until the patient has enough lymphocyte count?
It's depend per each manufacturer has their own criteria when to when to collect those patients, depend on the lymphocyte count. So we usually follow by product indication, product by product indication. In general, someone with very low lymphocyte count, let's say zero point 0.1 or 0, it doesn't make sense to collect because basically there are no lymphocyte to collect and to send to ship and manufacture. So in general, we think that adequate lymphocyte above zero point 0.1, zero point 0.2 it should be enough to manufacture enough T cells. However, the higher, the better. But again, some manufacturers they specify what is the cutoff number for the lymphocyte count prior to collection.
Thank you, Dr. Badr. There is a question in the chat box. What are the common symptoms of disease relapse post CAR T? And how frequent do you check or do you assess for, and what like tests that you do to check for disease relapse and response?
So in general, I mean, it depends on the location of lymphoma involvement. In general, you can see that there is progression in the lymph node size, presence of the B symptoms, and we usually monitor patient with the use of image. So that's the standard of care, how to monitor disease progression, use of PET scan, and typically we do PET scan at day 30 and day 90 for assessment of this. But in general, day 90 PET scan is the most one associated with long-term prognosis of those patients post CAR T cell.
Thank you, Dr. Badr. There's a question. We often hear that the patients are referred too late for evaluation. What are the common causes of these delays?
What is it? What's the question again?
The common causes for the delay of referral. What are the common reasons for delay in referral from
There are some.
oncologists?
Yeah, there are some data analyzed from different institutions across the world using survey-based data. As I said, many of them are related to a gap of knowledge about the what is CAR T cell, whether my patient is fit or eligible for the CAR T cell, whether my patient is safe to receive the safety of the CAR T cell or not. So that's gap in knowledge is not considered to be number one actually, and followed subsequently with the social economic status, insurance issues. So that's what usually lead to. I would say specifically about delay in the referral to start with.
And Dr. Badr, how can community oncologists and tertiary centers work more closely to ensure timely referral and coordination of care?
I think, as I said, enhance the knowledge about the importance of CAR T cell and indication of CAR T cell and importance of timely referral. Open channel of communication is very important to have direct communication with the centers that provide CAR T cell, direct communication with the oncologist, like the cell phone, the email, and others. So each center who treats CAR T cell, who treat DLBCL in the first line, I know that many centers they are able to deliver first line treatment for DLBCL. Should have a knowledge about whether their patient will be eligible for CAR T cell, and also should have an open channel with referral centers, the centers that can provide CAR T cell.
Okay, I don't see any more questions. Thank you very much, Dr. Badr, for the excellent and informative presentation. Your insights into the early referral, patient eligibility, and coordination between centers are extremely valuable as we continue to expand access to CAR T therapy. I would like to also to thank all of our attendees for joining us tonight and for the thoughtful discussion. Also, I would like to thank Saudi Society of Blood and Marrow Transplantation for organizing this webinar. And finally, I'd like to thank the sponsor, Gilead Kite, for sponsoring this activity. Thank you again, and wish everyone a pleasant evening. Thank you very much. See you in another event.
Thank you very much. It's a pleasure.
Thank you.